Let me introduce our first speaker, Lise Saffran, who is former director of the Master of Public Health program at the University of Missouri and also current co-chair of the Health Humanities Consortium. Her research, teaching and writing has been centering on the value of storytelling in the development of public health professionals and the ethical practice of public health. Her scholarly publications include explorations of authenticity in science communication and the power of fiction and fiction writing, especially in the context of disrupting biases. Her commentary on art, climate change, storytelling, public health, all of that can be found, among others, in The Lancet and Scientific American, but she's also a fiction writer, and one of her novels is entitled Juno's Daughters. She has also been writing short fiction that you can find in a variety of magazines. She's currently an associate teaching professor at the University of Missouri, where she teaches storytelling in public health and policy, and this is, I'm assuming, what she's also be going to be talking about us. As you can see, I haven't been sleeping all that well. That's why I'm sort of not speaking any proper language anymore. And today she'll be talking about mapping and crossing the boundaries between medical humanities and public health humanities. Welcome, please, and we're very much looking forward to your talk.
Thank you very much. I'm going to work on sharing my screen. So I am sorry that you haven't been sleeping. That makes me feel a little bit better, though, because it is 5 in the morning where I am in California. I'm so very pleased to have joined you here, though, today, and I'm glad. And thank you all for the support, the technical support especially, because there's nothing like zooming into a foreign country to have you feel your age and inexperience with technology. So yes, my name is Lise Saffran. I'm very happy to be here. I do work in narrative and public health storytelling, and I teach storytelling, creative writing to public health professionals and other evidence-based professionals at the University of Missouri. But I've also just completed a month-long workshop for the University of Iowa International Writing Program. And it's a roaming workshop. The first phase was in sub-Saharan Africa, and it's funded by the US State Department, and it's on telling healthcare stories. And so that was a lot of fun. And if you have any interest in that or would like to reach out to me directly, I'm very happy to answer questions and also engage in conversation. Yes, today I'm going to be talking about how the stories that we're telling and are being told around the COVID-19 pandemic, and in particular, the stories that center on physicians and other healthcare providers' experience of the pandemic, illuminate some of the borders and boundaries between traditional medical humanities and what I call and others refer to as public health humanities. So in particular, looking at that through a lens of narrative and how the narrative, the events that are being narrativized might look different from a medical humanities perspective versus a public health humanities perspective. So one of the features of the COVID-19 pandemic, obviously, I'm sure many of your other speakers have talked about the way that borders have been strengthened and illuminated, including borders between that we might not ordinarily be so aware of if we're on the comfortable side of the border, between those who have access to healthcare, those who have the kinds of jobs that they can work from home, those who live in communities that are historically offered privileges and not marginalized. Those borders have become even more clear to us as a result of COVID-19 pandemic. Those of us, again, who are on the comfortable side of them, the ones on the less comfortable side are pretty clear about those borders before. But one of the ways in which borders have really been broken down is this blurring of our professional and private lives. Because as we've retreated from public spaces, we have been interacting from our private spaces with each other. And so that includes things like telehealth appointments, media professionals zooming from home into TV stations, as illustrated here, where this science expert generously offered not just a view of her house, but also what she was wearing and the messy toys in her room. And this has been true of physicians and other healthcare providers, in that their personal experience and their emotional experience, their vulnerability and sense of risk for themselves and for their families has become part of the COVID-19 pandemic story. And in fact, one of the major elements of the story. So if medical humanities traditionally has as one of its focuses the fact that providers as well as patients are embodied and are multifaceted and more than, cannot be reduced to their professional selves, that they also have, this is of course true in the dynamic between providers and patients. The patients are embodied sometimes and the providers appear or represent themselves as less so. And medical humanities, one of the aims, as I understand it, is to bring that awareness of embodiment on both sides to the interaction. The COVID-19 pandemic and this story, and by story, it's important with public health students who are new to narrative. I have to underscore, this is probably not the case for this audience, but the story doesn't mean fiction. It just means the way that events are arranged in a narrative, and nonfiction stories are stories too. So the story of medical providers' experience has been a story of embodied experience in the pandemic. So for that reason, but also for the reasons that it has been obvious that while the COVID-19 pandemic is very much a biomedical emergency, it's clearly and broadly understood as an emergency that is also one of society, politics, community, social identity, clearly the issue of inequalities and disparities is part of the pandemic. So for all of those reasons, there have been renewed calls for medical humanities, health humanities, methodologies as part of the training of providers. And so this is an example of a recent New York Times op-ed from a historian talking about the ways in which, and I think in this op-ed blurs a little bit of those boundaries, in that she calls for a medical humanities approach, but talks about researchers researching structural and systemic issues, which I'll talk a little bit later, tends towards the public health humanities, even more than, say, traditional medical humanities. And always, as with any borders and boundaries, there is some permeability there. You know, I'll make a case, but it's not hot, cut and dried. There's some overlap. So I think it has to be said, obviously, that the current moment, the calls for medical and health humanities in the current moment are to address very real issues connected with the pandemic. But like I said before, these are issues that pre-existed the pandemic and weren't created by the pandemic for the most part, but rather illuminated by the pandemic. So just to review, I know you've been talking about medical humanities, but I'll talk about the ways in which these principles apply to public health humanities. The major goal of medical humanities and health humanities and public health humanities is to inculcate in professionals a certain set of attributes. It's not really necessarily to teach any particular content, although there are content areas, but to inculcate attributes of curiosity, empathy, respect, and tolerance of ambiguity in professionals who do health work. So I also want to just give you a very quick definition of how the definitions I'm working under, the assumptions I'm working under about the basic difference between medical health and public health humanities, because those are all terms that are thrown around quite frequently. So medical humanities, as I understand it, is the engagement with art, literature, history, philosophy, to inculcate those attributes, to help providers understand the multifaceted nature of patients, that they're complex human beings, and also the way that they themselves bring their own complexity into the relationship and to the work. So they're, that the subjectivity of their own experience and potential biases, their own embodiment. And it's focused primarily on, clinical settings and provider-patient relationships. Having said that about the clinical settings, obviously part of the understanding of patients as whole, complex and multifaceted human beings is understanding the ways in which non-clinical factors shape them and their health. So things like culture, environment, discrimination within the clinic and without, those are all part of medical humanities, historical discrimination. But again, in my understanding, it's kind of bringing all of those things to the patient-provider relationship again within a clinical context. So health humanities, which emerged from medical humanities, broadens that project out a bit to include non-medical providers, and also a greater emphasis on non-clinical settings. So disability studies is often a real prominent part of health humanities scholarship and teaching. And in part, I think it characterizes the difference in that disability studies focuses not just on the bodies of the disabled people, but the environment, social environment, economic environment, physical environment, the ways in which environments create disability for people. So it's a little, or it can be quite structurally focused and outward looking, but at the same time, it's still more or less, as I understand it, brings it back to these sort of individual interactions and the experience of individuals. And then finally, public health practice focuses on populations rather than individuals. So on communities and groups. We often say in public health, the community is the patient. It's focused primarily on prevention rather than treatment or cure. And the prevention focus of public health leads public health practice to be involved in things that one might not even consider health related if you're not in public health. So, focusing on the conditions of daily life, the conditions in which we live, work, play, and learn. So, public health really, its lens is quite broad, its focus is very far upstream, and the emphasis is on communities rather than individuals. And how the public health, not just public health providers interact with communities, but the public health system interacts with communities and vice versa. So just to make that a little more concrete, I'll give you an example of how, we talked about those attributes that medical health and public health humanities seek to inculcate in providers and professionals. Well, what does it look like if those attributes are missing? What is the kind of gap that this work is trying to fill? So in the case of medicine, a lack of empathy, humility, and curiosity might look like providers reducing patients, not only not seeing them as complex human beings, but reducing them down to kind of their presenting condition. So an example might be a doctor telling another doctor, could you go look at the, inflamed liver in bed 3? Like, that person doesn't have a name anymore. Not only do they don't have a family or a culture or desires, but they just have an inflamed liver, and they are the inflamed liver. So that would be an extreme version. But since public health doesn't really address patients, it looks different in public health. However, it's still the lack of empathy, curiosity, and humility are still a big problem. So in public health, how that might look is assumptions about how people and communities behave, like health behavior assumptions, and obviously because there are, social gradients in health, meaning that if you have less access and less resources, you are more at risk for poor health, and that includes health issues with behavioral determinants. So that might look like, well, why do people in certain communities tend to behave in certain ways? A lack of empathy, curiosity, and humility looks like making assumptions about those communities and their behavior. So, and that leads to obviously interventions that are based on those assumptions, focused on deficiencies in communities rather than strengths and resiliency. In my students, although, the social determinants of health are a primary focus of public health research and teaching and widely acknowledged to be much more determinant of human behavior than, say, whether or not people know that something is a risk. A lack of humility, empathy, curiosity looks like students and other professionals nonetheless skipping over the social determinants and going straight to like what's wrong with the people that are behaving in certain ways. So it's a question of attribution for behavior. And okay, so I study narrative. The ways that I think about and encourage my students to reflect about these issues is through narrative, through both telling better stories. So stories that are more, that are broad, contextual, that take into account, that are self-reflective, and also thinking about and looking about at the stories that are being told about various public health issues and communities. So asking questions like, what's the frame? Whose voices are being heard? Whose voices are not being heard? What's the context that's being placed around behavior? Because we obviously narrativize the world around us and interpret through narrative what we think is happening. And that includes what we think we're doing. So our role in the story is expressed through narrative. And so it's a really good way to think about our role generally and expose how we feel and think about other people and maybe some hidden assumptions in those stories. All right, so a couple of the stories that have bubbled up that are going to be very familiar with the COVID-19 pandemic. So this writer, Dr. Sarkar in JAMA, was talking about how obviously this hero narrative, various versions of the hero narrative, physicians as heroes, superhuman, willing to take risks that other people aren't willing to take, very clearly has been part of our COVID-19 pandemic story. And the ways in which it can be understood through medical humanities scholarship is the ways in which it both mirrors some of the art literature that we're familiar with, and the ways that it can misrepresent or actually support a dysfunctional sense of self for providers that's not helpful for providers or for the people that they serve. So that's an example of one of the really prominent narratives that we've seen in COVID-19 pandemic. But the other one that is very prominent, and the previous writer does talk about this a little bit in contrast, which is hero versus a vulnerable human, that I want to talk about and really talk about how public health humanities might frame it differently than medical humanities in a more traditional sense, is this issue of physician and provider vulnerability. So that has also been a big part of the story. So the superhuman hero doctors and nurses, but also the sick and tired doctor nurses the people who are not only worried about their own health, grieving for their patients and themselves and their experience, worried and grieving about their families and the fact that they may be bringing home COVID-19 to their family members, or the separation that they're experiencing because they're trying to avoid that. And then again, this prominent thread of narrative, which is the frustration as a result that physicians and providers are feeling and do feel towards the community at large, who, particularly the community of people who they view as potential future patients, people who are not behaving in the way that they need to behave in order to prevent infection. And so one of the ways I'm thinking about that in general is, it's kind, we often in COVID-19 language talk about it as people who aren't following the science. But I think you can also talk about it as a sort of a version of non-compliance. These are people in the community, they're not yet in the hospital on ventilators, but there are people in the community who the frustrated, angry, and burnt out physicians are viewing as non-compliant in advance because they're on their way, and how frustrating that is. So I bring that up because in medical humanities, thinking about why people are non-compliant through a medical humanities lens lends itself to those kinds of questions about humility, curiosity, tolerance of ambiguity, and respect. Understanding the context and viewing it through a lens of empathy, it's really difficult in this kind of crisis. It's never easy. But it is one of the major goals, as I understand it, of all kinds of health humanities work in medical, public health, and health humanities. So I'm going to offer, before I give you Chris Gurka's picture, I'm going to offer an alternative, more public health humanities lens to view that story of doctor frustration around the non-compliance of community members and COVID-19. So there are two writers and scholars in particular who I want to call your attention to. So the first, Chris Gurka and colleagues from Penn State University, looks at narratives and how narratives framed in a more public health humanities framework help us understand things like context differently. So what he and his colleagues have done is look at, so narratives and the storytelling that I teach it rests on the understanding and belief that most narratives are more interesting if they focus, at least in part, on individual cases and people, because we are interested in people's stories. We're more interested in individual stories because of their particularity and concreteness than we are in abstract big stories of, say, communities. So he and his colleagues look at how comparing stories that focus on individuals versus stories that focus on communities, and specifically how they impact a reader's understanding of the policy environment, sort of the larger context. Because again, public health focuses on upstream events. So rather than on as much on individual behavior, more on things like institutional context, policy environment. Those are where the real change happens. And those are the impacts on behavior that tend to be the most powerful. And so what he and his colleagues do is study, well, how do you, if you tell stories about individual behavior, do people tend to understand the context? Or do you need to tell stories about collectives and communities in order for people to understand the context? And what he and his colleagues found is that, and the risk that they were looking at is if you tell stories about individual behavior, you end up attributing all of the causes to individual behavior. So what he and his colleagues found is that, that there's actually not a big difference in individual focused or community focused stories, as long as the individual stories are contextualized in the broader sort of understanding of systemic and structural and political and institutional factors. So that, and that basically is what, in my teaching of creative nonfiction to public health students and professionals, I teach them to do, is to move back and forth between the micro and the macro. So while in some of the medical humanities work that I've seen emerging around the stories of doctors' frustration, there's been a lot of emphasis on burnout, which is a focus of medical humanities traditionally, on understanding how the stories map onto stories of art and literature. There has been less focus on what it means to be frustrated with behavior, and what's the context for the behavior. So I haven't seen a lot of that in the ways that doctor experiences have been presented in this narrative. The work of Chris Gurka and his colleagues offers kind of an alternative lens, which is more anchored in this public health humanities lens, which is, yes, doctors are frustrated. Yes, people are behaving badly, but what is the empathetic understanding and the contextual information that we need to add to that story to understand what's going on and to create empathy, and then ultimately change, because empathy, just being angry at people rarely gets them to change their behavior. So another person who is doing really great work in this area, and I view her, she's a public health professional and epidemiologist, but I view her also as a public health narrative person, is Julia Marcus at Harvard University. And her work, she's published a series of articles in The Atlantic. She comes from an HIV prevention background and a focus on risk mitigation. And her work, I think, is very squarely centered around this, an interpretation of the narrative that is anchored in humility, curiosity, tolerance of ambiguity, and respect, in that she is looking at what are the influences in the context in which people are behaving, what are their human needs, what are the messages that they're getting, what are their choices, and looking at this non-compliance, this not following the science, this frustrating behavior of courting risk and risking infection of yourself and others. What is an empathetic narrative of that behavior? And so, one of the examples is her, talking about the ways in which college students, especially at the beginning of this last academic year, how blame has been focused on college students for their behavior rather than on institutional environments, and also sort of, I come from Missouri, wider political contexts and environments. And so what's interesting about Julia Marcus and her work, I think, is that to me represents a public health humanities response to that narrative. It also has gotten a lot of pushback from people who are angry that she would suggest looking at that behavior with empathy. And so I think that's an interesting, people who might accept other kinds of empathetic approaches to noncompliance, particularly if the noncompliance is occurring among people who have been marginalized or disenfranchised or don't have access. Sometimes the noncompliance here is among people who are pretty privileged, and approaching that dynamic with empathy has resulted in a lot of pushback for Julia Marcus. And so if you're interested in that, you can find her work and the reactions to her work both on Twitter, I think, and in Atlantic and Atlantic comments. So my thing isn't, I think my slides aren't working. I have one more slide. Oh, there we go. Okay. So finally, I'm not even sure. I think we're okay. I think we're just about time. So my last slide, though, is, to point out that while I'm a scholar of narrative and an enthusiast of narrative, a storyteller and a writer, and I love teaching storytelling and writing to public health folks and medical folks, I want to acknowledge that there's a body of literature that provides really important critiques of narrative, that narrative is not uniformly a positive phenomenon. Angela Woods is a good example of somebody who critiques narrative. There's been a couple other really good papers that I can send to the organizers around the idea of medical humanities and narrative medicine, offering some risk in that as medical providers have access to patients' bodies, there's a certain amount of potentially, sort of autonomy that can be taken away. But when doctors engage in, or providers engage in narrative medicine, they have access to patients' everything, their culture, their home life, et cetera. Well, as I mentioned earlier, public health is even more that way, right? Public health basically considers its domain everything in your life, where you work, what you eat, your family relationships, your sexual relationships, your community structures and governance. This is all subject of public health inquiry, potential interventions. And, it's illustrated in part by this idea in public health of health in all policies. Education policy is public health policy. And so when we talk about the potential downsides and risks of narrative, that in public health, the fact that public health is potentially everywhere, the pandemic illustrates that, I think, in really visible ways to people, even maybe who weren't noticing. There are obligations that are conferred by that on public health structures, institutions, and professionals to be more self-reflective and to begin to really dig into and unpack the narratives that we're telling and accepting about communities, human behavior, and our own professional role, what we're doing, what we have a right to do. And I think, as I said before, that narrative can be one of the best ways to begin to look at those things if you do it consciously. So I think I've been chatting for quite a while, but and I don't know if you want to wait to questions till both talks are done, but thank you again for listening to my early morning blather. And it's been a great pleasure.